Hi, everybody. My name is Adam Pick, and I'd like to welcome you to the webinar titled Ask Dr. Gerdisch Anything. If I have yet to meet you, I'm the patient who started HeartValveSurgery.com all the way back in 2006. The mission of our website is really simple. We want to educate and empower patients just like you. And this webinar, which has had over 675 registrations from patients in countries all over the world, was designed to support that mission. Now, throughout the webinar, you're going to be in what's known as listen-only mode, but I would encourage you to submit your questions, actually fire your questions at Dr. Gerdisch throughout this webinar. So let's look at this very light agenda for today. I am going to introduce our featured speaker. We are then going to get very interactive with a Q&A session. And then I'm going to ask you to complete a very quick 5-question survey as we wrap up the webinar. Now, when it comes to the featured speaker, I am humbled that he is taking time away from his very busy practice in Indianapolis, Indiana. Dr. Marc Gerdisch is the chief of cardiac surgery at Franciscan Health in Indianapolis. And he has performed over 6,000 cardiac procedures. When it comes to valve surgery, Dr. Gerdisch hasn't performed 1, 2, 3, over 4,000 heart valve repair and heart valve replacement procedures. So we are going to get some incredible information today from Dr. Gerdisch. If you spend time with him, what you pick up, and what I've been fortunate to pick up over the past 10 years that I've known him, is he is focused on minimally invasive techniques. Atrial fibrillation is a passion of his. And he has a very deep understanding of how to create what are known as rapid recovery protocols. Why? Because he wants to get his patients back to their normal life as soon as possible. So again, when I talk about Dr. Gerdisch to people, I often talk about his commitment to valve disease. You might be wondering, how committed is he? Well, he's done all these procedures, but take a look at what his license plate reads. It is no joke, heart valve. And when we came out with our scrub cap, who was one of the first people to put it on and take a picture? It was Dr. Gerdisch. And I can tell you, I don't know where HeartValveSurgery.com would be without him, because he has been so responsive, so proactive, whether it is creating educational content with us in articles or videos. If I ever need anything, Dr. Gerdisch is there to help. But he's not just helping me, okay? And this is what I think is most important about Dr. Gerdisch. It's the results that he gets for who? For all the patients in our community. What you see here is actual patients from HeartValveSurgery.com who have found their way to Dr. Gerdisch, whether it's Linda or Todd or Tim or Janelle or Nina. He's got over 130 reviews and testimonials from patients at our website. And this for me is why I've loved working with you, Dr. Gerdisch, and I can't wait for today's webinar to share all the good information that you have. So on behalf of our community, I'd like to thank you for being here, Dr. Gerdisch.
Oh, thank you so much, Jan. That's a lovely introduction. It's my pleasure. So this is the favorite talk, my favorite talk that we do, because it tests my knowledge a little bit. I don't have to prepare because we're not talking about one topic. And I really enjoy experiencing the depth of understanding actually that folks have about their own conditions and how they explore their conditions. So glad to be here. Thank you.
Great. So let's not waste any time because we only have so much of it today. And I thought, Dr. Gerdisch, this would be a great question to set the context and the tone for today's session and for valve disease in general. This comes in from Mike. He says, I'm an active, soon-to-be 80-year-old who rode 2,000 miles last year on my bike, and symptoms have slowed me down. You can see here over a period of about 8 years, he's gone from mild to moderate. And now his doctors are saying, hey, you know something, for that mitral valve regurgitation, let's get a stress echo to learn a little bit more. He asked the question, should I be asking for a second opinion on referral? And I think another great question he asks is, can 8 years of mitral regurgitation cause enough overload to cause heart changes?
Very good question and really great information, right? Because we have a timeline. So that's super useful to us in this conversation. We also have a picture of a guy that looks better than I do. So I just think when I get on a bike and I'm near 80, I want to be anything remotely like that. So, there's so many interesting facets to this. One is folks who are in really good shape tend not to get symptomatic very early because they have a lot of reserve. And so it's almost a challenge in people that are very healthy, have good somatic muscle strength, they have great aerobic capacity. So it takes a lot to kind of set them back. And it's important to do what they've been doing with Mike, which is to monitor and look regularly. So you can see once they identified moderate in 2021, they stepped it up. And then you've got this kind of unique scenario where in 22, moderate to severe, mild to moderate in 23. So why is that? You have to kind of assess that. You want to look at the two studies closely. But then in 24, now he's got symptoms. And his symptoms are going to be real because this is a very fit person who knows his own physiology. His most recent echo shows us moderate mitral regurgitation, moderate enlargement of the left atrium. The thing that I'm most concerned about is are the words left ventricular dysfunction. So that in and of itself is likely an indication to fix the valve. And so in moderate mitral regurgitation, some of this is a little bit in the eyes of the beholder, right? I mean, you try to measure it. There can be multiple jets. There can be reasons that it quantifies in the moderate range and doesn't quite crest into severe. So in mitral regurgitation, we're always looking at other indicators. Does a person develop atrial fibrillation? Do they have tricuspid insufficiency? Do they have elevated right-sided pressures? Or do they have dysfunction of their heart, their muscle? So he's probably already ready to have surgery based on this. I'd have to see the images and look at the jets and understand the anatomy. I think a stress echo is a perfectly reasonable thing to do, though, because it will establish what happens to the amount of mitral regurgitation when he exerts himself and kind of put the equation together where the exertion increases the MR, makes him symptomatic. As far as second opinion, I think they're doing a pretty solid job, but it does look like this has matured to a situation that needs to be addressed. It reminds me, I had a guy about 8 months ago, 94 years old, bike rider. And to be honest, because he was 94, people weren't, kind of ushering him into therapy. But when I met him, I said, well, let's just fix your valve. We did a minimally invasive mitral valve repair and he's riding his bike again. So it's, chronologic age, certainly obviously in this case is not the issue. It's a matter of just deciding whether the regurgitation is quantifiably bad, which it looks like it probably is, and if there is an impact, and it does look like the left ventricle is starting to have dysfunction. So probably time to do something.
Dr. Gerdisch, I'm sure many people on the line like me are curious to know, you mentioned a 94-year-old. Do you know offhand what is the oldest person that you performed cardiac surgery on?
Yeah, I think 96 was the oldest person.
Wow.
It was actually a gal, and she was aortic valve and bypasses. And but so again, chronology isn't the key. It's this kind of full assessment. And it's also kind of somebody's drive and what their interest in staying alive is and how in the game they are. And it gets weighed against the complexity of the operation, the morbidities, the potential complications. But age is relevant, but it isn't a final determinant.
Great. Well, Mike, I hope that helped you. Let's go on to the next question. And this is a great one coming in from Jerry. And she says, I'm a 64-year-old woman and I work full-time. I have severe aortic stenosis, a narrow or blocked valve. I have allergies to metal. Is there a non-metal closure have you heard anything about Arthrex fiber tape? And Dr. Gerdisch, I had to put some of these videos of your patients. I think they're post-day op day, maybe 0 or 1. I don't know.
Yeah.
But I know that this is near and dear to your heart, no pun intended. So maybe we can talk a little bit about your protocol as well.
Of course. Yeah, I should be carrying my phone around every day because every day I'm kind of amazed at what people are doing. But so, as many people know, we have been extremely aggressive about absolutely stabilizing the entirety of the sternum when we have to do sternotomy, when we do sternotomy, because, minimally invasive surgery is wonderful. I do it all the time, but we still have to do a lot of surgery through a sternotomy. So our goal was to level the playing field, that the experience would be the same whether a person had a sternotomy or they had minimally invasive surgery. That way, we were always sure we were doing a complete operation. We were always sure we were giving them the full operation, and they would have the same experience. I mean, we're actually working on the incision now too. But so this is a great question because it layers into a couple of important things. Yeah, when we made this shift several years ago, we saw a steady drop in how long people stayed in the hospital. We saw essentially an elimination of the use of narcotics, and we saw a dramatic decrease in the number of people that had to go to extended care facilities. So this lovely 82-year-old woman here, who's post-op day 2 and goes home post-op day 4, went back to work 3 weeks after surgery. She didn't go to a rehab center. So we're very driven to make sure that people are back in action. Fiber tapes are super cool. We've started using them the last few months. I've developed a relationship with Arthrex. I like those things so much, and we're actually looking at new platforms for sternal stabilization. And one of those platforms is absent any metal. But the fiber tapes are definitely a very good adjunct to sternal closure. For us, it wouldn't be all we would do because we always do rigid fixation. We always completely fix the sternum so that it can't move with an orthopedic repair. But fiber tapes versus standard wire cerclage is a big upgrade. The tapes are wider. They don't cut through the bone. They get better compression, and they lie flat. There's no twisty things on the wires to stick up and get in the way and for people to feel. They're very flat. There is, like, as is mentioned, there's no metal. Now, I would advocate, though, for Jerry, that she be sure that she has a reaction to titanium. Titanium is incredibly inert, and the plates and screws that we use at present are titanium. And I would even say that if Jerry were to get a sample, she could come in contact with it, maybe put it on her wrist or something, and just kind of spend some time with it there and see how she feels about it, because it is that dramatic an improvement in recovery if you can get an orthopedic repair. If you can't do that, fiber tapes alone, done well, is a very nice step up from standard cerclage. So bravo to you for even knowing about it, Jerry, because we've just started to explore this. And it's being used now. It's starting to pick up some steam, but it's just being used in a few centers around the country.
Great. Thanks so much, Jerry. Thanks, Dr. Gerdisch. And let's move on to the next question from Helen. I probably get this, Dr. Gerdisch, about 50 times a year. Helen asks, is there anything that can be done about keloid scars?
Right. So this answer has 2 parts. I'm interested in this too, because it's kind of the last hurdle. If we can make the scars disappear, or we can make them so subtle that you can barely see them, then we really do change the entirety of the psychological impact of the operation. Because we've already dealt with the pain, we've dealt with the mobility, people are able to go back to work, they're able to do their thing, even when we do a sternotomy, but they still have a scar. And there's just a little, it's not it's not a huge trauma, but there's still some opportunity there to do something better. So, and keloids are particularly challenging. Certain people, there is a genetic component to keloids. So some people are going to get keloids no matter what you do. The question is, can we do a better job of healing incisions overall? And the answer to that is yes. I mean, look at plastic surgeons, right? What do plastic surgeons do? They have all kinds of gimmicks and devices and tension releasers and things that they put on incisions. So now we can't do exactly what they do because we have to think about reentry and the size of the incision and tension on the tissue, but that doesn't exclude us from making steps. So the things that we've done so far to try and make the soft tissue part better is we use a special type of suture that is a barbed suture that actually, when it goes through the soft tissue, which would be the fat and muscle, that you can't back out. So first thing we wanted to do is get all those layers to be really close to each other. And then for folks that would tend to hollow out that tissue, we actually use a powder that acts as a glue. So then now we've built up. Now we're building up from the bone. We've got that bone stabilized. We're building up from the bone, going through the soft tissue. We get to the skin now. So the skin, we're actually looking at some technology now, and it is actually related to Arthrex. They have the same company has a type of patch, skin closure patch at the end of the case that really looks like it enhances tissue healing, diminishes the risk of scarring, and diminishes infection risk. So it's got everything you want. And it has charge. It has a charge to it. It has an electrical charge to it that's chemical. So, and it appears to stimulate the healing of the tissue. So we're looking at that now. We're looking at is that last hurdle, and it may help with folks who tend to form keloid. With the things that you have to do to diminish keloid scarring are you have to get the tension off the incision, because any tension causes it to spread a little bit and form the keloid. And the other is to just diminish the inflammation there. And that's part of what our goal is with that process. And then if somebody has a scar that's really, driving them crazy, I don't think it's inappropriate to seek, if it's late in the game, obviously, to seek input from a plastic surgeon. And see if they have, they want to optimally treat the skin, because now everything else is healed. So if they want to optimally treat the skin. Great question.
Yeah, great. And we will stay tuned, Dr. Gerdisch, for what comes next with the new technology that you are referencing. Talking about hurdles, we've seen this tremendous increase in the use of TAVR over the last 15 years or so. I think cases have gone from about 4,000 in 2012 to over 100,000 last year. But that's really, as far as I know, been for aortic stenosis primarily. Lawrence asks, what is the latest information regarding TAVR for aortic regurgitation, a leaky valve, not a blocked valve?
Right. So an important question, because we haven't heard much lately. Yeah, it's true. The TAVR ride has been a wild ride, right? It's been amazing, kind of the explosive growth of the devices. I actually spoke to Steve Yakuba, who is a cardiologist in Riverside recently, kind of actually getting caught up on this because it's still a study valve. The one that's been in the study in the US is called a Jena valve. It's actually spelled with a J from Jena, Germany. And that valve is a very elegant device that kind of, when it's dropped in, it nestles into the valve and it grasps the leaflets. It has to be positioned perfectly. And when it is seated perfectly, when it's deployed perfectly, it works very well. It has some very particular constraints with respect to the fact that it's delivered in a large tube, larger than we presently use for transcatheter valves, which is usually not a problem in people who have AI, because they tend not to have vascular disease. The angulation of the aorta, the position of the aorta, can make it tricky to seat. And then it only goes up to a certain size of the annulus. So people with AI typically have big annuli. So those are all things that restrict the ability to implant the device. That said, after several years, they finally enrolled 180 patients in the study. That data was presented recently at the TCT meeting, and it looks pretty good. It's not ideal. They have a little bit of a high pacemaker rate. Because the aortas could be frail in these patients. They had a couple of people have aortic injuries that were important, but they're definitely headed in the right direction. They're moving toward getting it cleared for use by the FDA, but the FDA, of course, has to assess all these properties of the devices, and it will stay in limited release for a while. But eventually, I think it's going to make it to the market. There's another one called the J valve. There's the Jena valve, which is Jena, and the J valve. And that valve is just getting into the US market. I think it's an Asian product. It has some properties that might make it easier to implant. So that's where we are. We just, it took a long time to enroll the patients. The AI isn't as frequent. Most of those patients are good surgical candidates, but it is making progress. So it'll get to the market.
Great, great. And so we did a shout out to Deneen in the intro of the webinar, and here is her question, Dr. Gerdisch. She is a community member. Can't thank her enough for all the support she's given to our patient community. She asks, vertigo, flashing lights, and other vision changes are the only annoyances I've had to deal with after surgery. Are vision problems caused by open heart surgery, heart-lung machine, anesthesia, and or AFib meds? How long do vision changes post-surgery take to resolve?
So another great question, right? So something happens. It was temporally related to the operation. I didn't have it before. I've got it now. So probably it's related to what that patient just went through. And let's face it, heart surgery is a big deal. That's true. You're on the heart-lung machine. It is not terribly uncommon for people to have a little bit fuzzy vision right after surgery. It doesn't happen a lot, but it happens. And I think most of that is actually driven by edema. You have some extra fluid in every part of your body, and it resolves on its own. So that's typically what we see. A persistent vision change has to be evaluated by an ophthalmologist, especially being accompanied by flashing lights. So what could flashing lights be? Flashing lights could be retinal detachment. Flashing lights could be mini strokes. These are, I know that sounds terrifying and alarming, but the truth is flashing lights can be those things. Probably aren't in her case, but can be those things. And then vertigo. Vertigo is a really tough thing to deal with because you have to kind of be able to whinny it down to the mechanism. And vertigo can be due to low blood pressure that you're not aware of. Your blood pressure drops, or changes in your heart rhythm that you're unaware of. So vertigo in and of itself has its own algorithm for management, for assessment and management. So Deneen's going to have to get all of those. The relationship to the surgery is a little bit hard to tag on because this is unfortunately, or I should say fortunately, it's a very rare scenario, I have to say, that Deneen's going through. But, clearly she has to deal with it. Do I think it's specifically from one aspect? I really couldn't say, and I don't know. AFib meds, no. Only though, got to look at the rhythm. If you're on AFib meds, are there times when your heart rhythm is changing, causing the vertigo? Are the flashing lights, I assume if you're having AFib meds that you're on a blood thinner. If you're not on a blood thinner, the flashing lights could be thromboembolic events from atrial fibrillation. So first thing for me would be to converge on looking at the things that could really be devastating to me that could drive this. Could be the rhythm thing, could be the AFib, right? And then expanding into assessment for each of these as a separate component until you narrowed it down and treated it. But vision changes, again, I don't have a real frame of reference for that as far as timeline, other than a little bit of fuzzy that usually resolves within a week or so.
Great. Well, I hope that helps you, Deneen. And before we go to the next slide, I just want to let everybody know this is going to get a little bit graphic here because we did get a question about scar tissue. And so if you have any apprehension to seeing some blood, you might want to press pause or look away for this next question that's coming to us from Karen. And she asks, I received a cal valve replacement in 2019, which only lasted 3 years. Scar tissue was found. The doctors were not able to do a TAVR, valve-in-valve. So the valve was replaced again in 2023 with a cadaver valve. Please explain the development of scar tissue after a heart valve replacement. Is it the biological valve or the patient? What are the odds of me forming scar tissue again?
Yeah, so this is another great question. So that valve actually probably has a combination of scar tissue and then deterioration. So you can see the calcification in the leaflets and actually a perforation in the leaflet. But also, if we flipped it over, you would probably see some scar tissue that developed underneath it. So if we're speaking specifically about the scar tissue, we generally refer to that as pannus ingrowth. And it happens as tissue encroaches from the annulus underneath the valve. So we could have a very long conversation about this because it's super interesting. I'm going to try to narrow it down to just a few components. It is a fairly common occurrence. I have seen it with tissue surgical valves and TAVR. It is a process whereby that tissue, that scar tissue, grows in until it gets onto the leaflets, and then it prevents the leaflets from moving. It's happening on the underside of the valve. And we think it's related to, well, there are two things. One is just that cut edge of annulus, which is debrided tissue. It's active, it's inflamed, and it may promote the growth of tissue from it. The other is that typically when we implant a valve, we use a little bit of a Teflon pledget. Like we use very, very tiny ones. Some surgeons use very big ones. And those pledgets engender inflammation and probably promote some of that pannison growth in just some people, but it does happen, right? So if we can minimize the amount of material on the undersurface in the annulus, then we might diminish the pannison growth. And we've actually been looking at that lately by even redesigning the sutures so that we can get purchase of the tissue. So we get the support like we do with a pledget, but we have less of that bulk and less of that material there that might promote it. Now, the fact that I've seen it in a TAVR means it's not just that, because TAVRs don't have any sutures or pledgets. And so that means that there's active growth from the tissue. So that's partly the biology of the person. It's partly how big the valve is. It's partly how the annulus relates to the valve. So, for example, you've heard me talk about the Onyx mechanical valve, which we've done a lot of studies with. One of the advantages of that mechanical valve is that it has a skirt of pure carbon that drops down through the annulus of the valve, and it excludes it. So the annulus, if it tried to grow pannison, it would have to grow it down and underneath the skirt and back up, which is extremely unlikely, right? So there are some aspects of valve architecture that could support not developing pannison growth. It's an interesting choice to go on to a cadaver valve, and I'm sure there was a reason for that. They perform really well hemodynamically. They're a little bit challenging as you get remote from the implantation with respect to how you manage them if you need another valve. But they are hemodynamically beautiful. We use them for, almost exclusively for endocarditis, patients who have infections. But I've never heard of pannison growth in a cadaver valve of a homograft. I've never heard of that. So that may be, that is a way probably to solve that particular problem.
Yeah, Dr. Gerdisch, quick follow-up. We get a lot of questions from patients. A lot of them normalize around the question of durability of a bioprosthetic valve. How long is a pig valve going to last? How long is a cow valve going to last? Here, Karen had a situation that was only 3 years because of the scar tissue. Is this an anomaly? Is this an outlier? Or does this happen regularly?
Yeah, so it is a little bit of an anomaly. If we look at valve durability, it's definitely a bell curve. So you've got this, this tail on the short-term end that there's just there's a smaller number of patients. And then we have kind of the center, and the durability center of tissue aortic valves is 10 years. Now, remember that whole thing shifts based on the person's age and their biology. So a person who is young and or has cardiometabolic disease would have a shorter lifespan for their valve. Also, it shifts based on the size of the valve. So if you have a big valve relative to your body surface area, then the valve tends to last longer. You get more time with the valve because as it stiffens or fails, it takes longer for it to get to a point where the hole is actually small based on your body surface area, which is why we try to always upsize, always put a valve in that's a little bit bigger than the patient actually needed. So that's true, obviously, for tissue valves. Now, pig versus cow tissue, this is a tug of war that we've been going through for a long time. I think now the real importance is decision-making that tailors the long-term plan for the patient. So in some folks, a cow or pig tissue valve, they're going to behave a little bit differently biologically, perhaps. but they are really neck and neck with durability. Now, we do have some newer technology that folks think is going to last longer. We haven't proven that yet in the pericardial valves. We also have some advancements in the pig leaflet valves that have to do both with durability and with the opportunity to do a valve and valve later. And that overlaps with the architecture of the aortic root. So when we talk about all of this, it has to be folded into what the long-term plan is for the patient. So for example, somebody is 70, and this is easy. They're 70, they're getting a tissue valve. They have longevity in their family. Let's say, and they're 70, so they might get 14 years out of that valve. Now they're 84, they need another operation. Well, this is a good valve and valve. If you put a big valve in there and they have room in the aortic root for it, which one would they have gotten? Which tissue valve? Well, depending on the aortic root, that might actually make a difference because the porcine leaflets, the pig leaflets, when we put a valve and valve inside them, those leaflets stay a little bit lower. So that actually makes it a little bit easier to be sure that we have blood flow to the coronary arteries when we do the valve and valve. Whereas the bovine or the cow tissue, it sits a little bit higher when we put a valve and valve. It may have no consequence if they have a generous aortic root, but if they don't, it can have consequence. Therefore, we see patients that, well, now it's time for their valve and valve, and we look at the architecture and well, there's no room. So they get another operation. So it really depends on all of those components. I don't know which horse is the winner. I know what makes sense when planning the long-term framework for the patient's life. And sometimes it's not a tissue valve, right? Sometimes it's a mechanical valve. So I hope that explains that.
Yeah, I hope that helped, Karen. Let's move on to Patty, who asks, medication had maintained my blood pressure for several years. A sudden drop took place a month ago. My cardiologist paused my blood pressure medication. However, my blood pressure remained low for a month or so. My valve is now at a severe stage. Do blood pressure readings have a significant role in determining the progression of heart valve disease? And another common question is, do these fluctuations increase stroke risk?
Good questions. So having your blood pressure drop during the progression of aortic valve stenosis, it can actually be a little bit ominous because I don't want to alarm Patty. She probably feels okay. But think of it this way. Your blood pressure is a measurement of two things: the forward flow of blood out of your heart and the resistance in your vascular system. So as your valve is getting more blocked, you might have some diminution, some decrease in the amount of forward flow. And the system, your vascular system, will tighten up a little bit to compensate. But if you need blood pressure medication and then all of a sudden you don't, what's going on there? So your vascular system didn't change. You still have the same blood vessels that you had, but your aortic valve has gotten tighter. So that is, your heart is no longer driving the pressure as much. It's not an alarm like, oh my gosh, I need to go to the hospital. It's let's do a very nuanced evaluation of the echocardiogram. Let's understand how the ventricle is functioning. Try to really assess the cardiac output. And then probably, you already know the valve is severe. So maybe step up the pace a little bit in evaluation and treatment for this valve now that you've had a blood pressure change. I think this is a little bit of a signal that it's time to be very serious about it. As far as stroke risk, no, unless your blood pressure really drops. And that precipitates the lack of blood flow to the brain, obviously.
Right. So moving on, Dr. Gerdisch, we talked a little earlier on Mike's story about moderate mitral regurgitation. This is another topic in the moderate realm, but moderate aortic stenosis. I've been getting several more questions about this lately, and this one comes in from Gregory, who says, I'm a Canadian that has been diagnosed with moderate aortic stenosis and have been experiencing syncope and/or pre-syncope during mild exertion. This may include breathlessness, palpitations, and chest tightness. I am on a waiting list for further assessment with no end in sight. What are the risks of delay in assessment and treatment, meaning valve replacement?
Yeah, this is a very timely question because we have some recent studies looking at moderate aortic stenosis and the implications of treating it earlier. So, whereas I become a little concerned when we talk about treating moderate aortic stenosis because I don't want everybody who has moderate aortic stenosis to rush in and think they need their valve replaced or fixed or whatever. And I don't want clinicians to kind of abandon our history of management of aortic valve stenosis in favor of moving on them earlier for everybody with moderate aortic stenosis. That said, someone who has moderate aortic stenosis and is symptomatic, almost definitely, unless there's some other reason for them to have presyncope, almost definitely needs a valve treated now. Not tomorrow, but in the next several weeks, okay? Or maybe a couple of months. I'll give you a couple of months. But syncope is not, that's not something you play with. Once syncope, folks, is passing out. So that has, if it's not driven by something other than the valve, then the valve needs to be treated. And this also comes on the heels, though, of, like I said, a couple of other recent studies looking at very large populations of patients, trying to understand the impact of moving earlier on moderate aortic stenosis. There was an interesting study came out of Cleveland Clinic looking at, I think, 1,400 patients. They found in 1,400 patients with moderate aortic stenosis, this is how I remember it, about 22% of those patients with moderate stenosis had their aortic valve replaced. 75% of those were SAVR, surgical valves, 25% were TAVRs. And then they looked at how the two groups behaved if they had their valve replaced with moderate aortic stenosis or if they were followed for their moderate aortic stenosis. And it's a 10-year study with about a median follow-up of about 6 years. So that 6 years is a pretty good chunk of time. Survival was better for the people who had their valve treated. So that's an overall look. You would have to drill down on specifics of what actually drives that. So one of the things they recognized was that the people who had their valve treated had improvement in their left ventricular ejection fraction. They had a decrease in their right-sided pressures. So those are signals that means that there was already impact on the heart. It just wasn't recognized that it was just that valve. So for example, right now, an indication to do aortic valve replacement in severe aortic stenosis reads severe aortic stenosis with symptoms or severe aortic stenosis with a decline in left ventricular function. Well, if the people who had their valve fixed had an improvement in left ventricular function when their valve was fixed, it means they had a decline in ventricular function back here. So those are it's going to be these subtle changes, looking at the dynamics of the ventricle, how thick it is, how well it relaxes, what the performance parameters are. Are there any changes in that? And that's why their current recommendations for moderate aortic stenosis are an echo every 2 years. I disagree. Moderate aortic stenosis gets an echo every year because we want to know, if we can, we want to know about the changes in the heart. So my response to Gregory is that if indeed these symptoms are related to the valve, it needs an aggressive assessment now and consideration for intervention, because syncope is this, we see syncope for aortic stenosis, we treat it. And then there's this kind of broader swath of patients with moderate aortic stenosis that we just need to keep an eye on to make sure we're timing things properly.
Great. And Dr. Gerdisch, this next question is a follow-up to the earlier one. We actually have a picture of the Onyx valve there. And here is Jerry, who asks, are mechanical valves taking a sort of second place in the world of heart valve surgery?
Yeah. This is I get, folks are asking these questions that are so timely. And for a heart valve enthusiast, they really are the kind of things I like to talk about. If we were at a cocktail party, we'd be talking about the same stuff. My poor wife. So the reality of it is that it's true that if we look at overall what's happening in valve management, there's been a shift toward tissue valves. There's an explosive growth in transcatheter valves. We can talk about that and the consequences of having to take some of those out. And then there has been an overall decrease in the use of mechanical valves. It hasn't been quite as dramatic as you might think, though. So there's still mechanical valves going in, of course. I still, roughly 20% of my patients that have aortic valve replacement still have a mechanical valve implanted. And one of the reasons is this valve. So the Onyx valve, we just published data for both 1 year and 5 years of registry data for the Onyx valve. And before that, we had 10 years ago, a decade ago, we finished a study to show that this valve could be run at a lower dose of Coumadin. So what's the problem with having a mechanical valve? The problem that people worry about is bleeding because you're on a blood thinner. So there's two things. One is you have to check it. So there's a little bit of annoyance. There's something you have to do. You have to take a pill and you have to check the blood thinner. But the real thing people are worried about is bleeding. So in the PROACT study, which we did 10 years ago, we showed a 65% reduction in bleeding events by managing this valve at a lower dose of blood thinner with no increase in other risks, no stroke increase. In the registry, we had an 87% reduction in bleeding risk, again, with no increase in stroke incidence or complications. So fundamentally, what we have here is a valve that potentially lasts your entire life. It lasts your whole life unless it gets infected or some other kind of catastrophic event happens, that we can run at a lower dose of blood thinner and almost eliminate the bleeding issue. So they have kind of taken the second place, but I think we're seeing a little bit of an inching back for two reasons. One is we're learning that maybe implanting tissue valves and doing transcatheter valves and tissue valves in younger patients, we as a society, we've paid a little bit of a price. It's not devastating, but the redos, the valve and valves, the data that follow up on those, and recognizing that in some of these folks, especially who have longevity, for example, bicuspid valves who don't have anything else wrong with them, people with bicuspid valve disease tend to live a long time. They might be best served with a valve like this, as long as they're willing to manage the anticoagulation. So we're seeing a little bit of a swing back, and it's based on this data and the opportunity that this particular valve provides.
Yeah, and Dr. Gerdisch, this one just came in from Mark, and it's actually all about you. He asks, will a surgeon prefer a particular type of mechanical valve simply because they are more familiar with it? So they can install it quicker, which means less time on bypass.
Right. So good point. And my answer to that is the same always, which is that a heart surgeon, should be able to implant a heart valve. And it's true that, for example, the Onyx valve is a little bit more. One surgeon once told me, and this is a surgeon that I love. He's a spectacularly talented surgeon. He said they can be finicky. So he's right. There's a little bit of attention to detail. There's some things with sizing. There are some considerations with respect to the implantation technique, which I've only implanted this valve for almost 20 years. It's the only valve I've implanted. So obviously, and I'm a good surgeon, but I'm just a heart surgeon, just probably only as good as the average heart surgeon. So it's just a matter of knowing the details of the implantation. Could it take longer? It might, but it's on the order of minutes. So, several minutes maybe. So I think that if somebody just familiarizes themselves with the technique, we who implant them all the time are always available to talk to surgeons, that they should feel very comfortable implanting the valve. But it is also true that was one of the things that led to resistance to this valve dominating as mechanical valve implantation. But slowly that's turned as patients have become aware and surgeons have become aware that you can run it at a lower dose of blood thinner.
Yeah, and Dr. Gerdisch, I know you're a very humble guy, calling yourself an average heart surgeon. Specific to heart valves, I just want to ask you the question, how many heart valve procedures did you do last year?
Last year, probably just about 250. We have a kind of a broad spectrum of, from minimally invasive to multi-redo, multi-valve kind of stuff. So, and that's all I do, except for some aortic work that is not valve related. So,
right. Yeah. Correct me if I'm wrong, but getting back to your averageness, the average number of heart valve procedures, I believe, in particular the mitral valve, as indicated by the STS, the Society of Thoracic Surgeons, is 5?
Yeah, so 5 to 10, yeah. The aortic valve's a little bit more, right? Folks have a little bit more experience with aortic valves. But mitral valve surgery, it's true. In general, a lot of surgeons don't get the opportunity to operate on them. But it's also why, we have centers of excellence and places that focus on kind of this approach of really being able to globally manage everybody with aortic valve disease or with valve disease, rather.
Got it. I didn't want to make you blush, but I also wanted to ensure
Yeah, I understand.
that we understand that you are a world-renowned
I
heart
appreciate
surgeon.
it.
So thank you so much. Moving on. Great conversation there. Let's talk about Robin. She asked, does chemotherapy and I can never say this word, immunotherapy affect a bovine heart valve or cause congestive heart failure?
Wow. So again, very timely. There has been, in the last several years, there has been this focus, and it's not just about valve disease, it's the focus on understanding the impact of chemotherapy and immunotherapy, cancer therapy at large on cardiac performance. One of my cardiologists that I work with very closely, Vijay Rao, is a world authority, a global authority on this, and has developed a program that has been recognized internationally for managing folks who suffer the consequences or preventing the consequences of chemotherapy on the myocardium. So it doesn't affect the bovine heart valve directly, because the bovine heart valve is basically, it's tanned tissue, it's inert, it doesn't have cell growth, it's not being affected by chemotherapy. Chemotherapy, though, when you think about what's its job is to kill cells, particular cells, but kill cells. Meanwhile, while it's going after those particular cells that are particularly vulnerable to it, it has some global impact on the patient. So when you think about, for example, the GI tract, where you have this rapid turnover of cells all the time, people get a lot of GI symptoms, but it will pass because those patients are able to regenerate those cells all the time. You think of something that, for example, the heart, your heart cells are your heart cells. We haven't figured out how to regenerate or grow new heart cells yet. We're working on it. We're actually working on it in the valve space. And we're making some solid progress there, but we haven't perfected the ability to build new muscle. And human beings don't build new heart muscle. So if the toxicity of those chemicals affects the heart muscle, then the heart muscle will become weakened, and people do develop congestive heart failure from them. So there's a whole branch of medicine now, cardiology, that is focused on managing this. And that's the answer to the question.
Fantastic. And so let's talk about CardioWave. We got a question from a patient who met with you. This is Carrie.
Yeah,
She says, I met with Dr. Gerdisch in person 1 week ago before the ACC conference, American College of Cardiology, and asked him about the treatment process using sound waves. I really would like to try the sound wave treatment instead of having the TAVR. Does Dr. Gerdisch have an update for us?
So it's an interesting technology developed in France, in Paris, and they have a very limited number of patients that have been treated. They've had some interesting success with it, though. So what is this? This is a high-frequency ultrasound has been around for a really long time. It's a way to treat tissue. You can create scar in some tissue if you want to. You can use it to break up calcium. You can use it inside blood vessels to break up the calcium side of the blood vessels to open them up. We use it sometimes when we're doing transcatheter valves to open up a blood vessel that has a blockage so we can pass through it. But this is a particular application where high-frequency ultrasound is being directed outside the patient's chest into their heart valve. And it's essentially vaporizing the calcium on the leaflets. So it sounds very Star Trek, right? And that is. And so the interesting things are they haven't had any major strokes from it, which is cool because you're not getting big pieces of stuff coming off. They have had some people that have gone quickly on to have surgery because maybe they developed aortic valve insufficiency or whatever. But the interesting, the sexy thing about this to me is that if we can get some long-term data, which is we're nowhere near it, if we get some long-term, because my concern is that you morselize, you vaporize the calcium. Let's say you get a good result. The leaflets look better. And now how fast will they recalcify? We don't know because that tissue is abnormal and your body's already calcified it. So you're going to recalcify at some rate. I don't know what the rate is. But the really sexy concept is that if it's established as so safe that you can treat a person without any substantial risk, maybe this is what we end up treating moderate aortic stenosis with. That somebody has moderate aortic stenosis, if it's so safe. Now, this is years from now, probably at least a decade, maybe 20 years from now. But, you go in, you get your therapy, it recalcifies over a few years, you go in, you get your therapy. So, I'm just wondering if that might be something. I think its first role is going to be in folks that can't have heart surgery. That's where it might initially have or even a TAVR, whatever. And then after a while, as it gains some traction, has some follow-up, it may become, an available device, but we're way off, way off from this competing with our current technology, which is valve replacement or repair.
Right. So, Kerry, we're going to stay tuned on this one. And Dr. Gerdisch, we know valve disease is often underdiagnosed. We know it's often misdiagnosed. We know it's undertreated. And you can say a lot of that, those same problems exist for atrial fibrillation, which could be a very dangerous related cardiac condition to valve disease. We got two questions here. First comes in from Roy. He asks, I'm having a MitraClip procedure on Monday. Will that take care of my AFib?
Roy, this is such a good question. I know I keep saying that, but again, timely. So the answer is no, but I'm going to elaborate. It's a very interesting topic right now because the MitraClip, which is designed to treat functional mitral regurgitation in people who have a poorly functioning left ventricle, so that we can keep them out of heart failure and out of the hospital, has been expanded to use in what we would call the non-FDA approved world of using it for mitral regurgitation that is not that mitral regurgitation that is degenerative, that is related to deterioration of the valve itself. So with that, and there are situations where that makes complete sense. So I'll have, in the course of a year, I might have a couple of patients that are elderly, very sick, very frail, and we have a cardiologist, Dr. Sheikh, who can put these clips on, and I'll say, Saeed, can you please just put a clip on this patient because doing surgery on this patient makes no sense. And they aren't the one I talked about before. They're categorized in this other category, but they're also extremely high risk. It has made its way into these lower risk categories. I don't know what Roy's situation is. I don't know what his ventricular function is. I don't know why they're doing the clip. But the even if the mitral regurgitation is successfully treated, let's say they do the clip and they're fortunate enough not to have a leak, right? So you do the mitral clip, there's no leak, great. But the AFib won't be going away. And so this is the same conversation we had with transcatheter valves. For example, I just had a guy in my office today, 79 years old. We evaluated him first for transcatheter valve, had severe aortic stenosis, a trileaflet valve. It was an easy TAVR, but he had AFib. He had AFib for several years, but he also remembered going into AFib and that kind of what changed over time in his life. So we didn't do a TAVR for him. We did an aortic valve replacement and a maze for him. And he came into my office today, basically telling me that the cardiology office is across the highway. He said, I don't know, I was thinking about just walking over, but I couldn't find a way over. He's like, I feel so good, right? So because he's rid of the AFib and his aortic valve is working fine. So when we look at this now, there are ongoing studies looking at, for example, MitraClip there's studies looking at MitraClip versus surgery for degenerative mitral valve regurgitation, the place that surgery works so well that we do minimally invasive surgery for. And that's fine with me. But if you look at the population of people who have mitral valve disease, if you look at the MitraClip population, 67% of them have atrial fibrillation. If you look at degenerative mitral regurgitation, the folks that we treat all the time for surgery, almost 30% of them have, or maybe even 40% of them have AFib. So we can't ignore the AFib. AFib decreases your cardiac output, causes strokes, causes congestive heart failure, even if your heart rate is controlled, damages your left ventricle, causes atrial myopathy, changes the architecture of your atria. Now, there are going to be people that, yeah, maybe they're not supposed to have their AFib treated. Maybe they are so advanced and there's something going on and there's not a reason to treat their AFib. But if you're going to fix the mitral valve and the person has some reasonable opportunity for longevity and they have atrial fibrillation, the surgical data, the preponderance of surgical data is so powerful that we now have a class 1 indication in the guidelines, class 1 indication for treating atrial fibrillation at the time of heart valve surgery. So it's very hard to walk away from that. Well, someone might say, well, we're going to put the mitral clip on, and then we're going to send them to the EP, and the EP is going to take them to the lab, and they're going to fix the AFib. Possibly if you have new paroxysmal AFib, but if we look at persistent AFib or people who have a substantial burden of AFib, they're not very successful in that realm, nor is that if we look at the data, we don't see that happening. In other words, people don't get mitral clips and then go on to the lab to have their AFib fixed. So my answer is that you have to really take a global look and decide how important the AFib is. It should be addressed at the time of the procedure if the person has quality of life that they're after and they have some reasonable chance at longevity. And what patients with heart valve disease need to know in 2024 is that the Society of Thoracic Surgeons has made it a class 1 indication that if you have atrial fibrillation at the time of going to the operating room for your valve surgery, the surgeon should treat it. How will it be treated? That is a whole other conversation because different surgeons have different approaches to atrial fibrillation as a disorder. And I teach that course over and over again, and we have these unbelievable conversations with surgeons from around the country. But it requires that you have real insight into the impact of the atrial fibrillation and it not be ignored. The other thing to think about with the MitraClip procedure, because now I've taken several out, is that sometimes we can save the valve and repair it, and other times we have to replace it. So a valve that might have been repaired surgically, sometimes we're going to have to replace it because of the MitraClip. Those are all things to think about. This might be a perfect application for the MitraClip. I don't know the case, and it may well be that the AFib just shouldn't or couldn't be treated, but that would be I've given you the global assessment.
Yeah, super helpful, Dr. Gerdisch. And I want to go right to Gary's question. Just get incredibly specific in terms of what treatment means, because you referenced there's variable approaches to treating the AFib. Gary asks, is it common practice today in 2024 to close the left atrial appendage during heart valve surgery?
Wow. I'm not even sure doctors would ask me these questions. And this is something that we're looking at very intently right now. So we did a study a little while ago called Atlas. And we looked at the impact of closing the left atrial appendage in people who did not have a history of atrial fibrillation, but were at risk for it. So high CHA2DS2-VASc score, factors that we recognize contribute to the likelihood of developing atrial fibrillation. It was a pilot study to lead up to the study that is being done now, which is the LEAPS trial. And in that study, we're going to enroll 6,500 people from around the globe. And we will be closing the appendage of at-risk patients in a randomized fashion, so 1-to-1. It is not routine. It is routine for some surgeons to close all appendages. It's routine for some other surgeons to close appendage of people at risk. There is not an indication. In other words, there is not an STS or ACC recommendation to close a person's atrial appendage at the time of open heart surgery if they do not have a history of atrial fibrillation. That recommendation does not exist. But now there's a series of publications, including mine, that have looked at that. So, and we just published another one that Pat McCarthy's from Northwestern, I'm on the paper too, that looking at the data that exists out there in Medicare in insurance databases for patients who had their appendage closed without a history of atrial fibrillation. And we did see an overall improved survival long-term for folks who had their appendage closed. So what's the mechanism for that, right? Is it's got to be related to stroke reduction. So That said, though, that is not a randomized control study. That's not going to get us across the finish line for closing the appendage in people who don't have a history of atrial fibrillation. So that's why now we're doing this massive study that is going to answer the question. That's a randomization. So for folks who are having heart surgery, and if they fit into that category of risk, I would encourage them, if they're at a center doing the study, to enroll in the study, because we don't have a hard and fast answer for this yet. We don't have an answer to enroll in the study and help us answer the question. And if not, it's up to you to have a conversation with your surgeon about, managing the appendage. Does it make sense, and what the risks are, and how does it compute into your operation? But at present, we do not have an indication for it outside of AFib.
Got it. Well, I hope that helps you, Gary. And we are at East Coast time. We are at 7:03. So we've gone a little long here. And I think what we're going to do is we're going to go ahead and wrap up the webinar. We have over 76 questions. Unfortunately, we are not going to be able to.
We're passing up some good questions I can see here.
So I think we might need to do a part 3, Dr. Gerdisch. I think this was part 2. We got to go to part 3. And so what I
want that tricuspid question back. That was a good one.
Well, in appreciation of everybody's time, let's go ahead and find another way to get an additional Q&A on the books with you and our community. And so what I'd really like to do is look at all of these questions.
Oh my gosh, look at that. Oh, so good.
It's amazing. Yeah. And so as we wrap up, please don't exit the webinar yet. I just want to say thank you to our community. Your contribution to each other, to all of us focusing on our own health, is making a difference, not only in our own quality of life for the people on this line, but this video, we're going to create a video, an ebook about this webinar, so you'll be able to download it in the near future. I'm going to ask you to complete a very quick survey. Of course, Dr. Gerdisch, as always, thank you so much for your time and energy, for educating us and performing some really incredible surgery with some great outcomes, as we saw earlier. So thank you so much for being with us. And as we wrap up, I just want to say thank you for completing the survey that's going to be coming up on your screen right now. Thanks so much, Dr. Gerdisch, and thanks, everybody.
My pleasure. Well done.
Hi, everybody. It's Adam. I hope you enjoyed that video. And don't forget, you can always subscribe to our YouTube channel. Watch the next 2 educational videos coming up on your screen, or click the blue button to visit HeartValveSurgery.com.